I definitely didn't know a lot about this subject, so at least I now know more, and hopefully I can teach you one or two things you didn't know. So to start off with, I am, oh wait, sorry Jeremy, my slides aren't going to the next.
Just try with your mouse to click on the screen.
Oh, okay, yeah. Ah, thanks, cool. All right, sorry, let me just make sure. Okay, cool. So I'm going to start off with a clinical case. I looked for a case that we had seen at Helen Joseph, and I actually only found one case. I'm sure that there are more, but on our ID database, I actually only found one case. So I'm sure that we are missing a lot of hepatitis E, but it just illustrates that we haven't seen a lot if I could only find one case. So she was a 39-year-old patient. She presented with a weak history of confusion, abdominal pain, and vomiting. She was HIV positive. She was on TEE for 7 months, and her CD4 count on admission was 483, and she was virally suppressed. She lives in an apartment, or lived in an apartment in Johannesburg. She had running water and electricity. She didn't have a travel history or contact with any animals, and she had no hobbies to note. On examination, her vitals were normal. She was stable. She wasn't jaundiced. She didn't have any signs of chronic liver disease. On her neurological examination, she had psychomotor slowing. She had a blunted affect, and she was disorientated. On her abdominal exam, she just had some right upper quadrant tenderness, and there was nothing else to note on her other exams. In terms of investigations, I've just put up kind of the relevant investigations. She had a total billy of 9, conjugated billy of 6, an ALT of 200, and an AST of 172. Her INR was normal. She had her hepatitis A, B, and C were negative. They did an LP because of her neurological dysfunction, which was normal. She had an abdominal ultrasound and a CT brain, both were normal. And an EEG was done, and the comment on the EEG said occasional periods of slowing, but no seizure activity. So she was diagnosed as having efavirenz toxicity with neuropsychiatric manifestations, which were typical. But in terms of her slight liver dysfunction, the consulting doctors felt it was a drug-induced liver injury secondary to efavirenz. So her efavirenz was changed to Eluvia. This was a couple of years ago, so dolutegravir wasn't available. And she progressed really nicely. Her neurology improved, and her LFT went back to being normal. She kind of as an afterthought, her hepatitis E serology was done, and she was discharged and told to follow up at IDOPD. So when she came back to IDOPD, I think surprisingly, her hepatitis E, IgG, and IgM were both positive. But by that time, she didn't need any kind of supportive treatment, and her ALT was completely normal. So this case just illustrates that I'll be commenting on both of these things further into the presentation, but hepatitis E often presents either asymptomatically or with very mild symptoms. And the other thing is that a few studies have shown that patients who are diagnosed with a DILI often have hepatitis E, and so they're incorrectly diagnosed as a DILI. So this case does illustrate those 2 points quite nicely. So just going on to the topic for today, and that's hepatitis E, as we said. I thought this was incredibly surprising, and I searched kind of very hard to confirm this stat. Apparently, hepatitis E is the most common cause for an acute viral hepatitis in the world. There are 20 million new infections, 3 million cases of acute hepatitis, and 55,000 deaths every year. And I think that this is mainly due to the fact that we've implemented quite a few preventative measures for hepatitis A, B, and C. And so I think that we're diagnosing more hepatitis E, and perhaps because we haven't spent enough time on treatment and preventative measures for this pathogen, that it's now the top cause of an acute hepatitis. So it's a small icosahedral, non-enveloped, single-stranded RNA virus. And icosahedral means it's a it's polyhedron, sorry, with 20 faces. In terms of its history, this was amusing and fascinating for me. There was I don't know if it was, or maybe he's still alive, but his name was Mikhail Balayan. He was a scientist. So he's this gentleman in the photo on your right. He went to Afghanistan to investigate an outbreak of non-A and non-B hepatitis. It was amongst soldiers there. He ran out of time and wanted to take stool samples back to Russia to study this unknown virus, but he didn't have a way to refrigerate the samples and didn't have permission from his superiors. So he solved this dilemma by drinking a pooled filtrate of his patient's stool samples. He did add in a bit of yogurt, though, to make it a bit more palatable, and then returned to Moscow, where he did get very ill with an acute hepatitis. He then collected his own stool and was able to visualize hepatitis E for the first time in 1983 under an electron microscope. So if you thought your dedication to science was outstanding, I think you may need to think again. So 1980, it was first recognized as a new virus. And like I said, Mikhail visualized it for the first time in 83, and then it was sequenced in 1991 and named hepatitis E. So hepatitis E has several genomes, but the genomes that infect humans and swines are grouped into genotypes 1 to 4. So genotypes 1 and 2 infect only humans, and they predominate in the developing world. So genotype 1 is mainly in Asia and Africa, and 2 is predominantly in Mexico and West Africa, but they do occur in other parts of the world, as you'll see. Genotypes 3 and 4 infect humans and animals, and 3 is mainly in Europe and North America, as well as in Asia, and then 4 is generally in Southeast Asia. So this is what I was talking about. You can see that the yellow areas are genotypes 1 and 2. You can see they're in Africa and kind of more developing areas, in Mexico as well. South Africa at the bottom, you can see we're labeled as having genotypes 1 and 3. So that's over here. And 3 and 4 are predominantly in Southeast Asia, but 3 does occur in the rest of Europe. Okay, so in terms of transmission, starting with genotypes 1 and 2 over here, the main route of transmission is via contaminated water, so with human sewage, and so it's predominantly via the fecal-oral route. There has been documented direct transmission from human to human in genotype 1 and 2. Genotypes 3 and 4, the main way that humans are infected is by ingesting meat from an animal that was infected or is infected with hepatitis E, and it wasn't cooked properly or prepared properly. It has also been documented in shellfish that are infected with hepatitis E, and we're unsure if water that is contaminated, if it irrigates crops, if those crops are then contributing to infection in humans. And then blood products can, if a patient is acutely infected with hepatitis E and then donates blood, someone who is receiving that blood can then be acutely infected. And then vertical transmission has also been documented. Okay, so in terms of clinical features, usually, like I have said, usually developing countries involve genotypes 1 and 2. This can occur as an outbreak or a sporadic case, and it can be, or most of them are actually asymptomatic or have a very mild hepatitis, or very rarely an acute liver failure. So it's predominantly in patients who are older than 15 years, and it's most common in between 15 and 35 years. Men are twice as likely to be symptomatic. Mortality is 0.2 to 4% in patients who are not pregnant, and this is greatest in children that are less than 2 years old and patients who have pre-existing liver disease. So like I said, mortality in pregnancy is extremely high, so it's 10 to 25%. And this usually mortality is in the 3rd trimester. And if the patients do survive, they often have a lot of complications like preterm delivery. So genotypes 3 and 4, as I've said, they're mostly in developing countries. If you are acutely infected, most of them are going to be asymptomatic or very mild hepatitis. So those who are symptomatic are usually in middle-aged men. They often have a significant ethanol history or a pre-existing liver disease. And mortality is highest again in those with pre-existing liver disease. So I didn't actually know, but now I know that that hepatitis E can cause a chronic hepatitis. So you diagnose that when there is the presence of Hep E RNA in your serum or your stool for a duration of 6 months or more. This has only been reported in genotype 3 infection, and it almost exclusively happens in immunocompromised patients. So this has occurred in patients with HIV, in patients with solid organ transplants, heme malignancies, and patients on immunosuppressants like chemotherapy. So usually the type of person who's going to get chronic hepatitis, it does depend on the degree of immunosuppression. And the chemotherapeutic drug tacrolimus actually significantly increases your risk for developing chronic hepatitis. In HIV patients, it's usually patients with a CD4 of less than 200. And important to note that if you're suspecting chronic hepatitis E, often your serology is negative. And so to make a definitive diagnosis, you do need to confirm it with molecular tests. So extrahepatic involvement in hepatitis E mainly involves neurological symptoms, which I thought was fascinating. So most frequently, you can get a meningoencephalitis, you can get Guillain-Barré, transverse myelitis, peripheral neuropathy, and neuralgic amyotrophy. There's a whole list of other neurological symptoms you can get, but these are the most frequent. Hematological symptoms, thrombocytopenias and hemolysis. You can get a glomerulonephritis, not very frequently, but acute pancreatitis and thyroiditis have both been described. So this is the natural history of the infection as it relates to laboratory diagnoses. So the big blocks of color relate to RNA in the serum. So the red block is when RNA is in the serum, and the blue block is when RNA is in the feces. So in an acute infection, normally your incubation period is 2 to 6 weeks. So in this case over here, they've made it 2.5 weeks. Symptoms then appear. During your incubation period, your viremic window or your virus is actually highest. You then develop symptoms, and at the same time as developing symptoms, so like jaundice, your ALT, which is in the purple line, will increase. Like I said, the RNA peaks in the incubation period, and then it becomes undetectable about 3 weeks after your symptoms. So you can see here the RNA lasts until about 3 weeks. So you've got about 2.5 weeks over there since your symptoms started, and that's at that point your RNA becomes undetectable in your serum. Your RNA still can be detected in your stool though for about another 2 to 3 weeks. Your IgM usually, so IgM is in the blue line over here. This usually appears with your symptoms, and that can last anywhere from 3 months to a year. And your IgG, which is in the red over here, comes quite soon after your IgM, and that can last usually for longer than a year, but we're not really sure of the usual duration of that we don't think it lasts like a lifetime though. So I found this really helpful. Like, who should we be thinking about Hep E in, and who should we be testing? So in this table, they've divided it into immunocompetent and compromised. So in immunocompetent patients, they say anyone with an ALT of more than 300. I think that's, testing everyone with a slight derangement in the LFT may be excessive, but definitely in someone who you really don't know what the cause is. Clinical suspicion of a DILI. So like the case that I presented, and in several studies, it's been shown that patients who are diagnosed as a DILI are actually incorrectly diagnosed as a hepatitis E acute infection. So anyone that you're considering a DILI in, just keep, I think, hepatitis E in the back of your mind. Anyone who's got chronic decompensated chronic liver disease. I definitely have never thought about this, but apparently anyone with the GBS syndrome, you should think about it. Definitely a patient who has or neuralgic hematrophy, and then definitely a patient with unexplained neurology and a raised ALT. I've definitely never thought about that, and so I think I've felt that that's quite helpful. In immunocompromised patients, obviously all of the above. If they have a persistently elevated ALT, then you may be worried about chronic hepatitis E. And if they're at risk for hepatitis E infection, you may want to do annual PCR screening for them. Okay, so when diagnosing hepatitis E, it actually can be quite difficult, and it's diagnosed by serology and molecular tests. In terms of serology, we don't actually have any standardized assays, and the performance is very variable between the commercially available assays. Just for example, sensitivities range from 38% to 100%, and specificity from 60 to 100%. So you can't really be sure unless you know exactly what the specificity and sensitivity are. IgM is suggestive of a recent infection, but like I said, it can last up to a year. So that's, if a patient is still IgM positive, it doesn't mean that they were infected in the last month. It could have actually been a year ago, which isn't really recent. IgG is a marker of prior exposure, but this may not be lifelong though, and it may not be lifelong protective. In acute, so if you are suspecting a patient who has an acute hepatitis E, what is advised is to compare it with another IgM assay if you are able to. A rising IgG is very suggestive, IgG titers, or if you detect the RNA, then that's a definitive diagnosis. It's just that not everyone has access to PCR. In terms of the molecular techniques, these are still more accurate, but still very variable between labs. But if you do detect the RNA in the serum or the stool, then you've got a definitive diagnosis of active infection. So in terms of diagnosing Hep E in South Africa, we do have serology available at the NHLS. You saw that in my patient. They normally send it to Braamfontein to be done, and they use specific assay, which is called MP Diagnostics Serology Kit. In Tygerberg, the NHLS in Tygerberg does have an in-house assay for RNA detection, and so in state, if you want RNA or PCR to be done, it will have to travel to Tygerberg. They do genotyping, however, so that's great. And then if you're in private or have access to private, Lancet does do serology and PCR on serum and stool. So treatment, it's different for immunocompetent and compromised patients. So in acute immunocompetent patients, it's generally going to be supportive. If you have very severe disease and your patient is in liver failure, or they're just decompensating, specifically in genotype 3 infection, there has some people have used ribavirin, although this evidence is really limited. The problem is that most patients who die from this are pregnant women, and this is generally due to genotype 1 infection in developing countries. And currently, there is no definitive treatment for them other than supportive. So if you have an immunocompromised patient, whether it's an acute infection or a chronic infection, you can use this algorithm generally. So if you can possibly reduce their immunosuppressives, there's actually viral clearance in up to 30% of patients. If it does persist, however, you then can use ribavirin, although there haven't been any randomized control trials for this. Case series have suggested benefits. So you may want to try this if you're not winning after decreasing their immunosuppressants. And then a handful of cases have used pegylated interferon alpha, again, but yeah, evidence is limited and only described in case reports. So preventing, obviously, hepatitis E is going to be I think the most beneficial. So you can improve sanitation, specifically in developing countries where genotypes 1 and 2 predominate. Cooking meat properly, this is specifically in genotypes 3 and 4. And disposing of livestock feces properly would help a lot to prevent infection. There are 2 vaccine candidates available at the moment, or in studies. So the first vaccine in a phase 2 randomized control type trial, which was done in Nepal, showed protection against hepatitis E with an efficacy of 95%. And this is after a mean of 804 days of follow-up. It was noted though, so there are 3 injections that you need to have for this vaccine. There was no protection after only 1 dose and somewhat of a protection after 2. So you do need 3 doses in order for the protection to be 95%. And then just to note though that genotype 1 is the only genotype that has been documented in Nepal. So we don't know how effective this vaccine is in genotypes 2 to 4. The second vaccine that's available is the hepatitis E virus 239, and it's only licensed for use in China. In a phase 3 randomized controlled trial, it was protective at 100% after a follow-up of 19 months, which is very promising. And in China, genotypes 1 to 4 predominate. So it seems like it would be protective against all genotypes. Again, you need 3 intramuscular injections for this to have that effect. Okay, so that was kind of the basics of hepatitis E. I'm now going to go on to the evidence or the prevalence of hepatitis E in South Africa. There's actually very little research that's been done in South Africa, and most of it has actually been done in the Western Cape. There are 6 seroprevalence studies in South Africa, and most of the research is actually based on these 6 studies because they make up the bulk of any research that's been done in South Africa. So the first seroprevalence study was done in 1994 by Grabo et al., and they tested canoeists and students. They involved the canoeists because they were exposed to contaminated water, so sewage contaminated water when they were canoeing, and they were trying to see if that was a risk factor. So their mean seroprevalence amongst these students and canoeists was 2%. It was quite a small study though, and it was their population was mostly of the middle to higher socioeconomic communities, which isn't representative of our population. The next seroprevalence study is by Tucker et al., and this was done in 1996, and they tested people in Cape Town and then in 3 areas in the Eastern Cape. They interviewed or tested rural populations as well as urban people. 70% of the rural people that they tested lived in mud huts, and they didn't have access to clean water. So the overall seroprevalence here is a little bit higher, it's 10.7%. And you can see that the rural population that didn't, well, rural compared to urban, there was still a higher seroprevalence in the rural people. But if you didn't have access to clean water, then your seroprevalence went up even more. So this study suggests that this is that this hepatitis E is more waterborne in its transmission, and therefore more likely to be genotypes 1 and 2. So both of these studies, though, were done with screening tests that have very poor sensitivity. So we're not sure exactly how accurate these seroprevalence studies were. The third study was done by Horseman et al. This was done in patients admitted to Groote Schuur Hospital, and they were patients who presented with an acute hepatitis. Their seroprevalence is 29.5%, which is obviously a lot more than the ones from the 90s. And they had a trend of increasing seroprevalence with age, especially in patients who were more than 30 years old. The fourth study by Madden in 2014, they tested various patients, whether they were inpatients or outpatients, and they also tested healthy blood donors. They found a seroprevalence of 27.9%. So these two studies that were done in the 2000s were a lot more than the ones done in the 90s, and they attributed this to possibly because it was a different location. So those two studies, only one area was in Cape Town, whereas both of these newer studies were in the Western Cape. They thought that because travel was more accessible, we had a lot more migrants, that it could have been brought into the country. Our diet may have changed in recent years, and we might be testing patients more for hepatitis E. So the fifth study was done by Lopez. They tested IgG seroprevalence in healthy blood donors, and again found a seroprevalence of 25%, so very similar to the two previous studies. And the last seroprevalence study done in 2015 was by Maponga, and they again tested seroprevalence in healthy blood donors. Theirs was a lot higher, so 43%, and they attributed this to the high proportion of older blood donors, because as I'll talk about later, hepatitis E seroprevalence seems to increase with age. One person in their cohort tested positive for hepatitis E RNA. So what are our risk factors or associations with becoming infected with hepatitis E? So is it poor sanitation with an inability to access clean water or being exposed to contaminated water? Most of those studies so basically all 5 of the 6 studies actually are against this theory. When you would think that we have a high proportion of our population that doesn't have access to clean water. So Grobo in the beginning, the Canoeists didn't have a higher seroprevalence, which is against this proposed explanation. Maponga also tested Canoeists, and they actually found there was a statistically significant association with a decreased exposure or a decreased infection, Madden found that the type of dwelling, water access, and refuse disposal was not statistically significant with infection. And Lopez found that hepatitis A seroprevalence didn't mirror hepatitis E, and they both are orofecally transmitted, and so you would expect them to mirror each other in terms of their seroprevalence. So I'm not sure. So one study felt that, so Tucker felt that there was increased prevalence in patients who didn't have access to clean water, but that was kind of the only evidence for that. Increasing age has been shown in the research in South Africa. So Tucker had a linear relationship with increasing age and infection. Madden found that individuals 30 years and older had an increased risk with an odds ratio of 7. And Lopez, Mponga, and Korsman all found an association with an increasing age and infection. So the third risk factor is completely interesting. It's the consumption of pork. So again, you wouldn't necessarily think that that would be a risk factor in South Africa. It's mostly been described in Europe and Southeast Asia and in developed countries. So Madden found that if a patient had pork in their diet, then they had an increased risk of being IgG positive with an odds ratio of 2 in comparison to someone who didn't have any pork consumption. It can be very difficult though. That'll be on the next slide. So there was a study done in 2014, and this was again by Korsman, where they found that, so they took a whole bunch of pig-derived food products all over Cape Town, and they tested them for hepatitis E RNA, and they found that 2 samples of the pork liver paste had RNA present. And so they sequenced these 2 samples, and it actually clustered with genotype 3 and was very, very similar to the genotypes that had been sequenced in patients who'd been reported to have an acute infection at that time. So if you look on the graph to your right at the top, you can see these are all genotype 3 specimens. So right at the top over here, JP means Japan. So these are 3 samples on Japan, and then this is Great Britain, and then this is New Zealand. This is the sample from the pork liver paste, and these are the samples from 3 South Africans who had been reported to have acute infection. So you can see that the pig, or the pig-derived product, is very closely related to the infected individuals, and so obviously is compelling evidence for acquiring hepatitis E via pork consumption. Although, so what can be really difficult though to prove this is that when asking patients if they do consume pork or not, some patients may report that they don't, but they may actually be consuming pork and be unaware of it. So this was kind of horrifying. This was a study done in 2013 by Cawthorne. They took 139 processed meat samples from all over South Africa, different butcheries and shops, and they tested all of these samples for different animals to see exactly what made up these processed meats, and they found 68% of the samples contained species which were not declared on the product labeling, which I thought was a massive amount of undeclared meat products. So you'll see on this bar graph that so the percentage at the top of the graph shows the percentage of products that the species wasn't declared in. So 37% of products contained pork that wasn't declared. The next most common was chicken, and then beef, and then you can see some kind of unusual species. So buffalo was in there, a bit of goats, and some sheep. So that was, I didn't expect to find that in my research into hepatitis E. So continuing with the risk factors, does contact with pigs or other animals increase your risk? So in South Africa, we actually don't have any evidence on whether contact with pigs does increase your risk, but there was a study in the Eastern Cape on the prevalence of hepatitis RNA in pig feces, and they detected that 7 of 160 pigs that they tested were positive. So that's a 4.4% positivity or prevalence, seroprevalence. And so should we be concerned about our farming practices and disposal of pig or animal feces? I think, that should probably be looked into. Is HIV a risk factor? So unfortunately, again, we have no research done on this in South Africa, but there have been a few studies done in sub-Saharan Africa, and unfortunately, they're completely conflicting. And so that is an unknown at the moment. So I'm going to kind of end off on the only 4 cases of, the only reported cases of acute or active hepatitis E infection in South Africa. The first case report was in 2010, and this was in a patient who was 42. He was HIV positive. And if you just go to the graph, so in April 2009, his CD4 count, you can see, was 37. He started ARVs over here. So this gray line is when he started ARVs. This was in April 2010. And you can see as he starts ARVs, his CD4 count goes up, which is what we expect over there. And but at the same time, his ALT started to increase. And you may have thought he was on an efavirenz-based regimen. And so you may have thought that this was a DILI. His doctors, however, thought about hepatitis E, and so they tested him at this point, and he was IgM and IgG positive, as well as having RNA present in his serum. He continued to have his RNA present. His RNA was present almost a year later, which by definition is now chronic hepatitis E. But by the time his CD4 got to 324, he then cleared the infection. They actually had a sample from when he did his CD4 count here still stored. And so they tested his antibodies, the serology, and the RNA at that time, and his antibodies were negative, but he did actually have RNA in his system. And so they classified this as a hepatitis E iris. He was that when they genotyped the RNA, it was genotype 3. And so it's just something to consider when you have a patient who is HIV positive and they start to have a liver dysfunction or a rising ALT. It could be a DILI, depending on what medication they're on, but I think just keep hepatitis E in the back of your mind. So the third case report was in 2014. This was a 50-year-old female. She was a patient with autosomal dominant polycystic kidney disease. She received a transplant and was on MMF, tacrolimus, and prednisone. She presented to our hospital with malaise, fever, and jaundice. She hadn't had any contact with jaundice patients. She hadn't been in contact with any animals, no new treatment or alcohol. She had a bilirubin of 70 and an ALT of 1,700. She was IgM positive, and they did detect RNA. It was genotyped to genotype 3 as well. They reduced her prednisone and tacrolimus, and she cleared her infection after 3 months. The third case report is, again, also in 2014, and this was on a 54-year-old male. This was found in Madden's study, which I mentioned at the beginning, where they tested inpatients and outpatients, as well as healthy blood donors. So this is one of the inpatients who had presented with acute liver disease. He did have a significant ethanol history and had features of chronic liver disease. He was IgM positive. They did detect RNA, and again was genotyped to genotype 3. And unfortunately, this patient demised. And the last case report in South Africa up until up until the present time was in 2015. This was a patient in Maponga study who, again, was mentioned in the beginning. They tested blood donors, so healthy blood donors, and we don't have much of a history on this patient. We do know that he was a male, he was 51, and he had RNA present. They didn't mention whether he had IgG, or he would have had IgG positive, but I wasn't sure if he was IgM positive. That his blood donation was discarded once this was found. So, kind of summing up on South Africa and what kind of genotypes we have here, it's quite it's interesting, and you have to think about it, because are we genotype 1 and 2 like the rest of Africa and sub-Saharan Africa? We do have a portion of our population who doesn't have access to clean water and may be exposed to sewage contaminated water, but we haven't had any outbreaks, and our seroprevalence doesn't follow the hepatitis A seroprevalence. So both of those things are kind of against that. The other thing is that all 4 of our case reports have genotype 3, and we have pigs that have genotype 3 in their or pig products that have had genotype 3 present. It is plausible because pigs were introduced to South Africa from Europe, and so it could have come from Europe. Genotype 4 has never been reported in Africa or South Africa. So just to kind of end my presentation with a few things to remember, hepatitis E is endemic in South Africa, and so you do need to think about it. Consumption of pork is definitely a risk factor. It can have unusual manifestations, so think about neurology and patients that are potentially patients who have unexplained acute neurology and a raised ALT are patients you do need to think about hepatitis E in. Consider it in a patient who's HIV positive and they present with jaundice or a raised ALT. And then just also keep it in the back of your mind when you are diagnosing a patient as a DILI. Immunocompromised patients are at risk for chronic Hep E. And then I'm just going to leave you with the thought of that you might not always know what you're eating, which can be quite a scary prospect.
Thank you so much. That's absolutely superb. So guys, for anyone who has questions, just raise your hand or else type it in the chat box as we go. I mean, I suppose some of these conditions, I mean, always haunt me a little bit as how much we're missing, as you rightly say. Yeah. But I suppose the other way around is also true, where we've got serology that doesn't appear to correlate very well with active viremia. In the sense that the one. Yes. The one was very low percentage. So I suppose the flip side is also true, that just having a positive serology doesn't mean this is hepatitis E. Even IgM potentially. So that's another point to just kind of keep referring these patients down for actual virology assessment. To look if there's actual virus present. And then, as you say, some of the chronic ones may not be seropositive, which makes it very hard to. It's
even more hard. Yeah.
And yeah, we can have a look. We've got Stephen Korsman, who I believe is one of the authors on some of the papers. Lauren, if I've got that right.
Oh.
Stephen, do you want to make, because you've put some really interesting thing in the chat box, do you want to make a comment on that?
Okay, am I unmuted?
Oh, so yes, you are. Thank you. Yeah, go ahead.
You can hear me. Okay, I think that we have looked in the Western Cape at Western Cape people for the most part, and probably also Eastern Cape people that come to the Western Cape. And so I think the Western Cape studies are biased in favor of a developed area.
Okay.
And certainly in that context, you are looking more at genotype 3. Nobody since Tucker et al. Has looked properly in humans, at least in the Eastern Cape and in other more developing parts of South Africa. The study that looked at pigs in the Eastern Cape would obviously find the pig genotype, which is genotype 3, because they looked in pigs, but I don't think people have looked in humans properly. So we've probably got it there to a lesser extent. Our neighboring countries certainly have outbreaks. Maybe we're just not noticing them. Maybe genotype 1 is a lot less, but we don't really know that. Yeah, thanks.
Thank you. Thank you. It's really exciting that you that you listened, and thank you so much for your input.
Thanks. Great points. John, you've got your hand up.
Yes, thanks. So a little anecdote. When I was in the army in 1983, back in the dark ages, I was sent to Rundu in Kavango, Namibia, to help with the investigation of an outbreak of what they called Kavango jaundice, which was in fact occurred, was well known to occur in that part of the world. And at that point, the conclusion was that this was non-A, non-B, probably related to poor living conditions, because there are a lot of Angolan refugees in Kavango at that point, and they lived in informal housing and used river water. And so at that point, it was just called non-A, non-B, and specimens were stored at the SIMR. And in 2000, so more than 15 years later, we had someone visiting who had an interest in hepatitis E, and they unfroze the samples and showed that it was hepatitis E, which of course by then had been characterized. But as Stefan mentioned, there's been quite a lot of Namibian hepatitis E in recent years. I think an outbreak just a couple of years ago in Windhoek in informal settlements. So it certainly is all around. And then the other comment is on testing of donated blood. I know in some countries in Europe, it is tested for routinely. I think Netherlands is one place where that happens. But I don't know, and there's been discussion here with the blood transfusion services about whether they should start screening, but as far as I know, it's not done yet.
As far as I knew, it wasn't done as well, but I think that Stefan was saying it was done in the chat.
No,
sorry. that yes was responding to I am one of the authors that you were talking about. It's not
I
done
see.
In South Africa.
Okay.
It's not done in South Africa.
All right. Okay.
Thanks. And I mean, in terms of the food transmission hypothesis, I mean, is this uncooked meat, like uncooked pork that we're talking about, or is the virus thought to be stable even with sort of routine cooking? You know, if that doesn't sound, you can tell I don't cook a lot, but yeah.
So I know that you've got to get it to quite a high degree to eliminate it, but they actually, I don't know if they did specify that or not. I don't think, I mean, obviously the processed meats, again, I don't even know if they cooked or if it's kind of cured, or I'm not 100% sure in terms of processed meats, but I know that it does have to get to a certain degree, which is higher, I think, than most other meats. And but I'm not sure when they tested all the products from around South Africa. I don't know if that was uncooked meat or cooked. I think it was probably uncooked.
Can I comment?
Yeah, go for it.
When we tested the meat here from shops in the Western Cape, we tested uncooked meat, but when obviously the bacon arrives, it has been cured. It's not been, bacon isn't cooked. A number of things that we got were partially processed in terms of, none of them were cooked, but bacon is cured, and then the scary thing is that the liver spread is actually not cooked. It's just minced, mashed, ground up liver with spices. That is where we found the virus.
Yes.
I think the big thing is if you cook your pork like you're supposed to avoid cysticercosis, you are safe. The problem probably is washing your hands properly after touching pork, touching the uncooked pork. And then, of course, the uncooked, you get pig liver sausage, which is not cooked. It's basically like pieces of liver, mashed liver that are turned into sausage and dried. That is not cooked, that is high risk. They've actually had an outbreak associated with that in Italy. Liver spread uncooked, and we have no idea what's going on in our shellfish. We think that's a big problem, but nobody's really looked at it properly.
Thanks. That's really, really, really helpful. Thanks. So just reading some of the comments as well. Patrick from Nigeria. So must we eat pig meat in Nigeria? Should we be advised to do the screening test for Hep E virus? Want to know if it's curable. So Lauren, you did talk about the treatment of it. So I mean, I think in terms of the first thing, I mean, if there's a reason to test for hepatitis E in Nigeria, it sounds like you should be testing. But in terms of the treatment, Lauren, do you want to reiterate that?
So most people will clear it, and treatment is only supportive. It's only if you have patients who are severely ill, who aren't pregnant, but who are in acute liver failure, then you might want to try ribavirin, although the evidence is very limited. And then if you have chronic disease, you normally are immunosuppressed. And at that time, you either decrease your immunosuppressants if you're on them, or if you're HIV positive, you go on to ARVs. So yeah, I mean, most people will clear it. And if you're immunocompromised, then it's kind of, we'll have to, you got to try out a few things. And if that doesn't work, you can go on to other treatments, but the evidence is not great. It's only a few case studies.
Thank you. And then just lastly, I think, so to maybe to Stephen or John or anyone else who does who's involved with the testing specifically, do we have any idea about the specificity of the serology testing in South Africa, on the assays currently that we use?
Tygerberg testing, they use one of the top serology tests, so specificity is pretty good. Sensitivity is pretty good as well, but IgM, you do tend to miss them. The problem is, as Lauren pointed out in the beginning, or near the beginning, is that if you're immune compromised, you don't have antibodies. So finding it in those patients, you need to have their immune system boosted before they're producing antibodies. So I would not call that sensitive enough to warrant using antibodies only as a diagnosis. But specificity is not a problem.
Thank you. That's really, really helpful and enormously, I think, eye-opening for me in terms of some of those chronic patients with, undefined hepatitis. After you've, as Lauren says, I mean, it wouldn't be the first rung of testing. I mean, we wouldn't. But if you have the clinical picture that fits and your tests so far have become negative, that would be something to consider. So I think that's a really useful point. I've got a hand up from Galaxy J4. Galaxy, go ahead. Or if you've got your hand up, go ahead, because you may not know your name is Galaxy J4. No takers?
It's from a distant galaxy.
Yes. All right. If you do have your hand up, go ahead. Otherwise, we'll wrap it up. All right. So I think we'd leave it there. But Lauren, that is incredibly useful. Thank you so much. It was a really good talk, and I think really has reinforced some kind of key points for many of us, myself included. And thanks again. Oh, sorry, we've got a comment then. Galaxy J4 is typing saying, I still want to know what are the likely symptoms of hepatitis E virus. Lauren, do you want to cover that bit?
So it's if you're going to be presenting, it's with an acute hepatitis. So jaundice, vomiting, nausea, abdominal pain, fever, malaise. Yeah. Yeah, and high ALTs and yes, and then on investigations, yeah. And maybe your INR is up, or I mean, generally your ALT is going to be your most helpful investigation when you're trying to diagnose someone or think about diagnosis.
Great. Well, thank you very much again, and thanks, both to Lauren for a superb talk, but also to those who contributed to the chat as well. It's nice having you present, Stephen, for this talk, and John as well.
Yeah.
Very, very helpful. Thank you so much.
Thank